Mr. Chairperson, sir, today I feel honored to be invited to deliver this talk on hepatitis E in pregnant women, facts and figures, and have titled it Unmasking of the Unholy Alliance between Hepatitis E and Pregnancy. I shall narrate some extraordinary events which have happened recently in this remarkable human interest story. I wish to take this august audience to pre-hepatitis E era of 80s, when a major controversy had existed in data on viral hepatitis in pregnancy between the West and the East. Following many discussions and debates in international forums, a consensus was built that the reports of higher mortality of viral hepatitis in pregnancy from developed countries were based on retrospective analysis of hospital admissions and were interpreted as a reflection of biased hospital-based data collection. However, at that time, I held an extreme belief that the epidemic of jaundice and resultant mortality in pregnant women had a hidden saga and needed to be uncovered. The Mashu Gulmarg epidemic of 78 gave me a golden opportunity to explore this intriguing relationship. Withstanding all challenges of hard weather, primitive healthcare, team funding, and health risks, we envisaged an ingenious door-to-door survey and data collection of the epidemic area and completed 4 surveys at 4 to 6 week intervals. The data collection from this led us to believe that the epidemic was caused by an unrecognized viral agent and called it epidemic non-A non-B hepatitis, which finally led to the discovery of hepatitis E through a remarkable human interest story. However, apart from meticulous description of the disease, we produced unbiased field data about the relationship between viral hepatitis and pregnancy. Pregnant women, when compared with age-matched men and non-pregnant women, were 8 times more susceptible to occurring acute hepatitis, and this occurred across all 3 trimesters, though more often in second and third. Acute liver failure was recorded in over 22% of pregnant women, selectively in the third trimester alone. Around 44% of third trimester pregnant women developed acute liver failure. 8 of the 18 third trimester pregnant women developed acute liver failure with 6 deaths. Subsequent studies and partial genomic sequencing have shown that this and subsequent 10 recorded epidemics in Kashmir were caused by HEV genotype 1, which is similar to Burmese strain of HEV. Apart from increased incidence and severity of hepatitis E in pregnant women, HEV acute liver failure is an explosive disease that has a high occurrence of cerebral edema, DIC, and GI bleeding. Mortality in HEV acute liver failure is better than those with non-HEV acute liver failure, and pregnancy per se did not influence the mortality rate in such patients. All these distinctive features of HEV acute liver failure in pregnant women needed an explanation. Over the years, we and many other groups in the country have identified an unholy alliance between hepatitis C and pregnancy in various forms in the epidemic disease, sporadic disease, and acute liver failure. Once infected, pregnant women have major obstetric and fetal complication, and a high proportion of newborn babies born to infected mothers are HEV infected, and a high proportion present with massive hepatic necrosis causing high perinatal mortality. Several attempts and studies published on the pathogenesis, including the hormonal and immunological status of HEV-infected pregnant women, were done. However, these failed to explain several basic issues about this adverse relationship, including fundamental question, why this relationship only exists with hepatitis E and only in the Indian subcontinent, and why the disease is so florid with high occurrence of DIC, and what triggers vertical transmission with high fetal and neonatal deaths. Of late, the unholy alliance and adverse relationship between hepatitis C and pregnancy are being unmasked. Here is the evidence. Recently, we did an extensive search on genetic makeup of the agents from epidemic, sporadic disease, and acute liver failure, and came up with a convincing finding that relationship between hepatitis E and pregnancy is genotype specific and occurs only with genotype 1 alone and not with genotype 3, 2, and not certainly with genotype 3 and 4. What is so special and specific in HEV genotype 1? HEV genotype 1 alone and not any other genotype, apart from having 3 ORFs, has an additional unique ORF4, which overlaps ORF1. ORF4 expresses under stress and is driven by a cap-independent sequence located in ORF1 itself. ORF4 is not present in other genotypes, and ORF4s from rodents and ferret HEV are not homologous to human ORF4 of genotype 1. ORF4 is made of 158 amino acids, is highly disordered protein and rapidly degraded through proteasomal degradation, and has a fundamental role in regulation, replication, and pathogenesis of HEV genotype 1. Per se, it replicates poorly. However, it is the ORF4 that markedly promotes viral replication of genotype 1 as it forms complex with multiple viral proteins and enhances polymerase activity. Though HEV genotype 3 lacks ORF4, it was shown that ORF4 protein activity is transferable from genotype 1 to genotype 3, which promotes an enhanced viral replication. The existence of mutation-based proteasomal resistant ORF4 in some HEV infected patients has been described, and which may contribute to negative patient's outcome. HEV genotype 1 powered by ORF4 protein has a propensity to infect and break the integrity of the maternal-fetal interface. This interface, as shown, is highly complex structure and shows immune tolerance to allogenic fetus and host defense against pathogens through a crosstalk between decidual immune cells and several types of trophoblast cells of the placenta. The potential to infect, damage, and break the maternal-fetal interface has been shown in non-decidualized human endometrial cells and also in ex vivo maternal-fetal interface. HEV genotype 1 was more efficient than genotype 3 in viral replication and production and showed more severe tissue damage, that is necrosis and apoptosis in the placenta, with upregulated bad pathogen cytokines and downregulated good cytokines as shown. The massive production of these cytokines contributes to and even may be responsible for severe maternal disease. The placental infections break the maternal-fetal barrier and mediate vertical transmission of HEV to the fetus. Based on the breakdown of maternal-fetal interface, HEV genotype 1 is vertically transmitted to fetus, is the cause of severe fetal and neonatal hepatitis, and significantly contributes to poor maternal outcome. In a seminal paper, we showed that mother-to-child transmission in 6 of the 8 babies born to mothers who were HEV infected with 2 neonatal deaths from massive hepatic necrosis. Vertical transmission of HEV infection occurs exclusively with genotype 1 and has been documented to occur in 33 to 100% babies born to infected mothers. Babies born to HEV acute liver failure mothers are more often infected and have more often severe liver disease. DIC in pregnant women with HEV acute liver failure occurs exclusively in those who have delivered babies with severe HEV liver disease. This suggests that severe fetal and neonatal liver disease may trigger DIC in the mother. Healthy pregnant women experience a sudden and marked increase in estrogen and progesterone, which, other than helping the fetus to grow, dampen maternal immune response and promote immune tolerance to allogenic fetus. Pregnant women with HEV have higher hormonal response, which among other things may impair immune response further and promote viral replication. Although healthy pregnant women show complex immune tolerance as described, pregnant women with HEV acute liver failure have a wide range of immune dysregulation, which may alter innate and adaptive immune responses, help viral replication, and mediate severity of liver disease. Thus, HEV genotype 1, charged with ORF4 protein, has a unique property of enhancing viral replication, causing significant pathological damage to the maternal filter interface, which loads maternal blood with cytokines and breaks the barrier to cause vertical transmission. Vertical transmission causes severe fetal infection and possible release of toxin to maternal blood, triggering severe liver disease and DIC. On the other side, enhanced hormonal alterations and immune dysregulation have a wide nature, promote viral replication with negative maternal outcome. Management of HEV infection pregnant women requires a team approach determined by stage and severity of disease in the mother, occurrence of obstetric complications, and severity of vertically transmitted disease in the fetus and neonate. Patients with impending signs of acute liver failure need intensive care management. Liver transplantation team, if available, must be involved. Therapeutic termination of pregnancy and its beneficial effects on the liver disease in the mother needs serious consideration, as events in the maternal fetal interface and fetus are involved and are incriminated in the severity of maternal disease. There are several reports, including one from our group, showing that if therapeutic or spontaneous termination is accomplished early on in the first few days of acute liver failure, it has beneficial effect on maternal survival, as is seen in this graphic representation of an acute liver failure mother depicting favorable events in her health following an early spontaneous delivery. The Chinese hepatitis E vaccine has been a breakthrough. The vaccine has completed successful phase 2, phase 3 trials and is commercially available in China in 30 microgram doses to be administered at 0, 1, and 6-month regimen. As of today, the vaccine is not available in India. Once available, vaccine needs to be considered for use in various settings and population groups, including pregnant women, to assess its role in controlling hepatitis C infection. There are limited data on the safety of vaccine in pregnant women and its effectiveness in preventing severe disease. I thank you for your patience. Thank you.